Good morning and welcome to the final evidence session of the year for the House of Commons Health and Social Care Select Committee. Today we are pursuing our inquiry into maternity safety, and we're going to look at a number of important issues that could reduce the number of babies and mothers harmed or even dying during childbirth. And these include the advice that mothers receive on different ways to give birth, the number of scans they receive before childbirth, and safe levels of staffing. We'll be talking to the Chief Executive of the Royal College of Midwives, to the President of the Royal College of Obstetricians and Gynecologists, and also to Donna Ockenden, who is leading the inquiry into baby deaths at Shrewsbury and Telford Trust and published her interim report last week. But before we talk to them, we want to look at the very specific issue of the higher than average level of harm amongst mothers and babies from certain minority ethnic groups. So on our first panel, very pleased to hear from Chloe and Tinuke, two black mothers from London who both had poor experience of NHS maternity services, and following that set up the 5 times more campaign, named because black mothers are 5 times more likely to die during childbirth than other mothers. And their petition to Parliament has generated a huge amount of interest, and in fact this part of the committee session has been set up in collaboration with Parliament's Petitions Committee. And alongside them we have Professors Marion Knight and Jenny Kurichuk from MBRRACE-UK, which is a national collaborative programme that researches maternal and baby death and harm. But first, very warm welcome to Chloe and Tinuke, and Sarah Owen is going to ask them some questions. Over to you, Sarah.
Thank you, Chair. And just to declare that I have met Chloe and Tinuke before, having heard their presentation from 5 times more. But I just want to start with a couple of questions. So, Tinuke and Chloe, could you share your experiences of maternity care with the committee, please? And how did this lead to the 5 times more campaign?
Thank you. And thank you for inviting us here today. I'd like to start off by saying that black women are not a homogenous group, and we don't speak for all black women. However, through our own personal experiences and engaging with black women in our various networks of over 25,000 black women across the country, we have seen that black women are consistently having poorer experiences. I will now be going on to speak about some difficult experiences of pregnancy and childbirth, which some listeners may find disturbing. I wanted to start off by giving my story of giving birth to my son back in 2017. There were signs of preeclampsia, high blood pressure and protein in my urine from midway through my pregnancy, but it wasn't picked up, I wasn't monitored, and I wasn't given any medication for it. It wasn't until a last-minute midwife appointment at the end of my pregnancy that it was picked up. And by this time, I was so swollen, I was advised to go straight to the hospital by my midwife, which of course was really worrying to hear as a first-time mum. When I got to the hospital, I was told that I can't leave the hospital without giving birth to my son. And as a result, I was induced the next day. The midwife that induced me reassured me that it would take at least 24 hours for the hormones to work. But when I started feeling pain a few hours later and asked her to check, she wouldn't check me over. She didn't believe that I was in labor. And I was left for hours without any pain relief. And by the time my waters finally broke and I was checked over, the midwife realized that I was 8 centimeters gone. I had indeed progressed really quickly in such a short amount of time. I was rushed to the delivery suite as my baby's heart rate was dropping. And in the end, I ended up having an assisted delivery because honestly, I was too exhausted and I didn't have the strength to push my son. I was left feeling like I wasn't important, like I wasn't listened to at all, and that my pain actually wasn't taken seriously. The more I spoke to women in my immediate network through Mums and Tea, which is a social network for mothers to connect, I found that my experience was not an isolated one. I wasn't alone in having a really poor experience, and a lot of Black mothers felt the same way, which increasingly became a cause of concern for me. The MBRRACE report came out in 2018 telling us that Black women are indeed 5 times more likely to die, which validated our voices and our experiences. One of the key messages with the campaign is that we always like to say there are real people behind these statistics. And I'm going to give you 2 accounts of some women and families who have also been really deeply affected by the disparity that we're seeing. Delissa Parks unfortunately passed away in 2015, giving birth to her daughter. And I will now read some words from her mother, Sylvia. The doctor informed me that it was normal for baby's head to be high and free due to the fact that Black women's pelvises were shaped differently. He held on to his truth at the inquest into her death, but this was addressed by the coroner, who advised that this was unsafe. I will always maintain that her death could have been prevented if she was taken seriously when she attended the hospital on the day before she died and was sent home. I'm not a medical expert, but I'm her mum. Sylvia is the guardian and full-time carer of Delissa's daughter, Soraya, who was born with multiple complications due to the nature of her birth. Shamika Dockery ended up with retained placenta that wasn't detected until 11 days after giving birth to her son. She went to seek help from health professionals on numerous occasions. Her midwife said that she was sweating through bed sheets at night because she was breastfeeding. Her GP said that she was in pain because everything was stuck together. And when she finally did get help in the hospital, she was told she couldn't receive surgery straight away because her head wasn't falling off, even though she was taken to hospital in an ambulance. Shamika now has to live with chronic abdominal, hip and leg pain, which has affected her life and her relationship with her son, even to this day, 7 years after she's given birth. These stories are just a small example of what it is like to give birth as a Black woman in the UK. Why the campaign? I am showing my age here, but looking back at the previous confidential inquiries into maternal death, before it was called MBRRACE, we see that as early as 1991, when my mum gave birth to me, she had a higher risk of dying as a Black woman. They just didn't know just how much because data on ethnicity was not previously collected in the UK. Over the years, we see that gap widening, and we see that Black women are overrepresented among the deaths. The MBRRACE report in 2018 mentioned that action was needed to address this disparity. This is a consistent issue which we believe has been worsening over the years and has led us to believe that it was just not important enough to those in charge of maternity services and the decision makers, as the number was steadily rising as opposed to going down. So I decided to join forces with my friend Clotilde, who is the founder of the social enterprise Prosperities, which supports Black and South Asian mothers through their pregnancies. We both saw this as a problem, and we started the 5 times more campaign as a way to address this, because we feared that if nothing was done, our daughters and our loved ones, should they choose to give birth, would be 10 or 15 times more likely to die based on the current trajectory of the statistics that we have been seeing. And we have been able to harness the power of social media to build and grow our campaign and speak to Black women from across the country. Over the past year, we've been really busy raising awareness of the campaign and the statistics and driving for tangible action for change to happen fast. Thank you.
Thank you, Tineke. I'm going to move on now to, can you tell us a bit more about the 5 times more campaign and your petition? I don't know whether Chloe's covering this.
Yes.
I will cover it. Thank you. So we started a petition because we wanted to improve maternal mortality rates and healthcare for Black women in the UK. The petition reached over 187,000 signatures. We were able to gain a lot of signatures in a short amount of time, and we're waiting to debate the petition in Parliament. So the support we have gained from the petition has led us to partner up with organisations such as the Royal College of Gynae. We are now a member of the Race Equality Task Force, which they have created earlier this year. We have also collaborated with them to create 5 steps for health professionals so they can take better care of women. We have also partnered up with Clifton Chance, who has helped us on the legal basis. Clifton Chance provided us with a pro bono legal support and have created a guideline clearly stating women's legal rights, and the guideline explaining more about the NHS complaint procedures. We have also partnered up with the Positive Birth Company, which have given us free pregnancy digital package that we offer out to 100 Black women every month. We created the UK's first Maternal Health Awareness Week, which we had hundreds of people reposting and using our hashtags, over 100,000 views online, because we had an online event. And we also launched the partners steps for birthing partners to support the birthing women or the birthing person. And we submitted evidence also, and this is one of the reasons why we're here, to the Health and Social Care Committee when they had a call for evidence. We had 415 women who participated and with the survey that we submitted. We also, there was a call to the ethnic disparities and inquiry. There was an open call, so we submitted evidence for that just recently. We have given talks to university students, upcoming medical professionals, doctors, midwives on our steps and things that they can do to reduce inequalities. We have written articles for the patient safety learnings, AIM journals, and been featured in various publications such as the BMJ, Guardian, and much more. Just recently, we presented at the NCT AGM conference and the MBRRACE conference and International Midwife Forum Conference and the Royal College of Midwives. We, at the 5 Times More campaign, we don't want to scare women, but rather empower them with the knowledge and support through our 6 recommended steps that we created for Black mums to be able to advocate for themselves, but also to empower them to take control of their pregnancy and to know their right. We also have resources, fact sheets, and multiple partnerships to other organisations. Thank you.
Thank you so much, Chloe. Before I come on to my last question, I just wanted to say thank you so much for your evidence, and you're both an inspiration. Chloe, you touched on this question. You talked about the 6 different points that people can have. What do you feel needs to change to address this disparity and prevent future harm from occurring?
Can you repeat the question? Sorry.
What do you feel needs to change to address this disparity and prevent future harm from occurring?
Well, there needs to be greater investment from the NHS to understand why there is a huge disparities in health outcomes for Black women. We believe this issue is deeper than mortality. There needs to be more research into much wider issue that is co-created and includes Black women and lived experience. Black women who are experts in the fields need to be part of the research. There's a lack of representation in strategy and delivery, and when we are involved or invited, it feels often very tokenistic. There is no data on near misses, the mobility and illnesses, and the poor outcome from Black women. And I know that I'm not alone in thinking that we can't all change this, but something needs to be done. Once we can start to uncover these experiences of Black women going through the maternity service and making their target, to do better, we'll have a better outcome for all Black women.
Thank you.
Thank you very much indeed. Well, that's a perfect moment to bring in Professor Marion Knight, who is Professor of Maternal and Child Population Health at the University of Oxford and also works with MBRRACE, specialises in maternal health. I know you have just completed some research on the safety of mothers and babies, so thank you very much for joining us. Tell us your reaction to what Chloe and Tinuke were saying, and also about what your research indicates.
So, I mean, many of the points that Chloe and Tinuke raised are absolutely crucial, I think, to this problem. Particularly, they reflected the issue of women presenting repeatedly and their symptoms not being recognised as significant, or their voices not being heard. which is definitely an important point in terms of thinking about maternity safety and the issues that we see underlying maternal deaths. I think there's a point I need to make clear at the beginning when we're thinking about maternal deaths. And we're not talking about maternal deaths in childbirth as a result of childbirth complications. The majority of women who die from medical and mental health problems, which are made worse by pregnancy or by the care they receive because they're pregnant. So we do need, when thinking about safety and particularly thinking about addressing inequalities, to think much more broadly than just maternity services. And so that the messages that I have drawn from the more recent research, we do really need to think much more widely than the professional groups, than just midwives and obstetricians. We undertook a specific inquiry looking at potential biases, structural and other biases that were affecting the care of women from different aggregated ethnic groups. And again, just reflecting what Chloe and Tinuke said, we describe these as aggregated ethnic groups because, as we know, all Black women are different. And I think we must remember that women are individuals. We found that there was no difference in the causes from which women were dying across those aggregated ethnic groups when looking at Black women, Asian women, white women, or women from other groups. There were no differences when looking at the care of women who died. In our overall assessment of the quality of care, we felt that across every ethnic group, about 40% of women might have had a different outcome, so they may not have died if they'd had different care. What the group did identify, however, were 17 clear biases in the care that women received on the basis of this additional, more detailed inquiry. And I was just going to talk about the three main themes, the three leading themes that our expert assessors, which covered a range of professional groups and researchers and from all different ethnic backgrounds. The first was what they called "not like me," and that was the most, that was observed most in Black women, where women, assessors felt that staff needed more listening and learning and nuance around women's background, making sure that women received individualized care, thinking about place of birth, language, cultural factors, socioeconomic background to enable the most appropriate care, as opposed to this sort of default one size fits all. And the second most frequent theme we observed was complexity, and complexity, clinical, social, and cultural. And when we look at the women who die, the vast majority of women who die have multiple and complex problems. And our systems are really not set up. There's definite evidence of structural biases which impact on these women receiving the care they need. For example, clinics based at different hospitals requiring different appointments with communication not necessarily occurring between them. Clinical complexity, this as a theme, was observed equally amongst all ethnic groups. So it was a theme for white women, for Asian women, and for Black women. And the third most frequent theme observed was microaggressions. And this was perhaps most predominant amongst Asian women, but also identified some of the themes that Chloe and Tinuke and the women in their network have expressed quite clearly. So, for example, racial or ethnic stereotypes, such as Black women having lower pain thresholds. A particular concern was women who have language, so who don't necessarily speak English fluently, who agitation was assumed to be due to mental health problems when they were actually seriously physically ill, and that misinterpretation on the basis of their language. And clearly, language issues did spread across a number of the themes. And our assessors certainly felt that a continued reliance, for example, on family members as interpreters was a potential microaggression, because certainly if you're relying on a young nephew, for example, to interpret for you, you're not going to be able to disclose some of the potentially personal issues that are affecting you in your pregnancy.
Professor Knight, could I ask you, is there any evidence the problem is getting worse or better? What are the trend lines behind this?
So if we're looking at the disparity in maternal mortality rates between black and white women, the disparity has been getting wider between. So when I took over leading this inquiry, there was about a threefold difference in mortality between black and white women, and it reached in the report we published in 2019 about a fivefold difference. And one of the reasons I, as Chloe and Tanuka picked up, felt that in 2018 I had to put this front and centre was because I couldn't go on just documenting this. And they've done a fantastic job at raising awareness since that report and helping to get some of the actions started.
Thank you. I think Tanuka wanted to come back in with something that you thought could be put right.
Yes, I did. Thank you so much. So in terms of, oh, that's the baby, sorry. So in terms of, solutions and what we think needs to change, as I mentioned previously, my traumatic experience wasn't a unique one. And I think that's what the issue is. Based on the collective stories we have heard, which is backed up by the research, there is clearly an issue, as we know. And maybe I don't speak for all Black women, but I know what would have been helpful for me. And when I speak to other women, they say the same thing. And on that basis, we honestly do think that the NHS does need to commit to a target to close the gap and end this disparity immediately. Black women only account for 4% of births, according to the MBRRACE report, yet are 5 times more likely to die. This issue is one that has been going on for decades, and there is a clear indication that something needs to be done right away. The Human Rights Committee pointed out in a recent report that the NHS acknowledge and regret that they have no target. So we think that this would be the perfect starting point to work towards something targeted to end the disparity. Based on our consultation as well and the written evidence that we have submitted to this inquiry, Black women are not being given information to make informed decisions about their care and birth options. We found that out of the 400 Black women that were questioned, about 78% of them did not receive advice or guidance on how to make an informed decision about home births, 70% about water births, 73% were not presented this as an option when it came to cesarean sections. 85% of Black women were not given advice or guidance about having an assisted birth, so would not have been in a position to understand what this entails. And certainly in my personal experience of having to have an assisted birth, I didn't even know what it entailed. I wasn't given any information about it prior. 94% of the respondents were actually unaware of the role of the Health and Safety Investigation Branch, and also were unaware of how to make a complaint when they had bad experiences during their pregnancies and childbirth, even when they were at a risk of losing their life because of the negligent care that they had received. And out of those respondents that did engage with HSIB to raise a concern, 74% of them did not receive a follow-up. So on that basis, we recommend that more awareness should be raised so that Black women can make more informed decisions and be confident going into their pregnancy and childbirth and beyond. The last thing I wanted to add was we would actually like to minimize the use of the word BAME when it comes to maternity services. The term BAME, as you know, stands for Black and Asian Minority Ethnic. And it's a term, basically, we feel, that puts anybody who isn't white under the same category. Labeling women as BAME disregards the fact that Black women have had a higher risk and have done so for a very long time now. And we believe that, especially when it comes to maternity services, you should say Black if you mean Black.
Okay, thank you. Laura Trott's got a question for you, Tanuka.
Yes.
Thanks, Chair, and thanks so much, Tanuka. I just wanted to follow up on the stat that you just gave about the fact that 74% of Black women who you surveyed who contacted HSIB didn't actually get a response. That is absolutely extraordinary. Can you give a little bit more detail around that? Was there anything that anyone said to you particularly about their experience with HSIB that you'd like to share with the committee?
I don't have any specific experiences of people that actually, tried to complain to HSIB, but I was very shocked when I saw that as well. And I feel like overall, from speaking to the women in our community, it's a very, there's just a sense of, what's the point of even complaining? Because we don't know if anything's going to happen. We don't know if anything's going to change. And I think that statistic very, quite rightly shows that.
Absolutely right.
That's your question.
We'll ask about it later on, I think, in terms of the people coming to the panel. Thank you so much.
You're welcome. Thank you.
Thank you. And finally on this panel, I want to bring in Professor Jenny Kurichuk, who is Professor of Perinatal Epidemiology and Director of the National Perinatal Epidemiology Unit, also at Oxford, and also works with MBRRACE. Thank you very much for joining us. I wanted to ask for your reaction, first of all, on the basis of your research to the issues faced by some Black women, as we've heard about this morning, but also in previous evidence sessions, we've heard evidence from Sweden, and we know that if we had Swedish neonatal death rates, 1,000 more babies would survive every year in England. And I just wanted your overall view as to why it is that we have that disparity.
Well, thank you very much, Chair. And I'll pick up on the issue of baby deaths in particular, because I think Marion has already spoken to the issue of mothers who die. And to highlight the fact that overall our perinatal mortality rate is currently falling, and it's fallen by about 15% from 2015 to our most recent figures, which we published last week in 2018. And we're seeing a fall in all groups of different women, but nevertheless we see a disparity between the experience of babies dying, so those are stillbirths and babies who die in the neonatal period, for women who are Black and Black British, where there's a twofold increased risk of babies dying compared to white babies, and a 60% excess risk for Asian and Asian British babies. And that disparity hasn't changed over time, and if anything, there's a suggestion that it might have slightly increased. So what we're doing in relation to all the national initiatives to reduce perinatal death is clearly working, and the rates are going down, but it's clear that we're not managing to tackle the difference that different women experience. So we have a few insights into what the differences may be due to, and in work we've carried out in Oxford, looking at a range of adverse baby outcomes from neonatal death, infant death, and preterm birth. We know that between a quarter and a third of the variation between different ethnic groups can be explained by deprivation. The problem with that as an explanation is that deprivation in itself, as a headline figure, is important, but it provides little understanding about what that variation is due to. And we certainly need more research to explain those differences. And the differences are not the same for different women, as Tanuka mentioned. Different women, we lump women together because that's the way we get the statistics and the figures, but we have to remember that underlying that there are individual women, and there are women from all different ethnic groups. Some of the excess variation might be due to higher risks that some of the groups of women face. So, for example, we know from Bradford that congenital anomalies explain the higher mortality that we see in babies of Pakistani origin, and that's been very well documented in the Born in Bradford data. And some of that's due to an increased risk of actually being at an increased risk of having a congenital anomaly, but also different variations in acceptability and uptake of, for example, termination of pregnancy following prenatal diagnosis. In terms of our understanding, we need to undertake further research. It's clear that we need to do that, and we do have further research underway, and we'll be able to tell you about that at a later point. So there's quantitative work being led by the MBRRACE team in Leicester. We're also about to embark on a confidential inquiry into the deaths of babies to mothers who are Black and Black British, and that will start in the new year. And I think the other thing that it's really important to remember in the middle of all of this, for the individual families who experience a baby death, they need to know why their baby died. And for 90% of babies, of parents of stillbirth, the review that they're going to get of why their baby died will be a local review. And we have the perinatal mortality review tool now, which can help staff in trusts to carry out robust, standardized reviews of all the stages of care, so that it's possible to identify through every stage of care where improvements in care can be made. And this is an incredibly powerful tool to help not only understanding for parents of why their baby died and any implications for future pregnancies, but also to learn the lessons so that care can be improved. And that's for everyone, but bearing in mind that there are increased risks for women of particular ethnic origin, that will have a disproportionate effect on understanding why their babies die.
I just wondered, because you're someone who looks at all the research, what you think the main things are that they do differently in a country like Sweden, where they have a neonatal death rate around half ours. What would be your main recommendations?
I don't think I'm in a position to answer that question. They have their healthcare system is organised differently. They refer babies differently. They provide different neonatal care services. I don't think I have a good answer to that, I'm afraid.
Well, let me ask a question in a different way that maybe you can answer. On the basis of your research, you've talked about particular risks surrounding people from certain minority ethnic groups as having a higher than average prevalence for both maternal and baby deaths. What are the other groups of people where we see a higher than average risk of these tragedies happening?
So women who are from a deprived background across the board. So there's a gradient of risk if we look at it by area-based measures of deprivation, so that there's a twofold increased risk for women who are in the most deprived compared to the least deprived groups, and women who engage in lifestyle-related factors. So, for example, smoking, there's an increased risk of stillbirth. The risk changes with maternal age, so women who are young women and older women have an increased risk, but a lot of these factors are related to each other, as I've described in the way that deprivation is related to ethnicity. So identifying the individual risk factors and the extent that we need to modify those risk factors the research really is still underway for a lot of these issues. Okay. So I think we are a little way behind in terms of our understanding for baby deaths compared to mother deaths at the moment.
Okay, thank you. Barbara Keeley and Taiwo Owatemi have got some questions for Professor Knight, who I know wants to come in on that point. Barbara first.
Yes, the question was around these higher maternal mortality rates among different groups of women. I wanted to ask, do the causes of mortality vary between ethnicities? Because I think it's important for us to understand that.
No, they don't. So the causes, when you compare across the different groups, the causes don't vary. It's still 2/3 of women die from medical or mental health problems, which you can get outside pregnancy, but in which have been made worse by pregnancy. And actually, the point I wanted to come in on, when thinking about the women who die, almost all of the women have pre-existing or known medical or mental health comorbidities. And that's why, for me, we really have to start before pregnancy, because we need to make sure that women's medication or health are optimized as well as they can be before they get pregnant. But also, and that picks up the point that Tanuka made about women being informed before pregnancy. And that's obviously beyond and outside maternity services, because we're talking about other medical specialties or indeed general practice. And we also note that there's a bias simply because you're pregnant. And women who have really concerning symptoms, and heart disease is a case in point, so the leading cause of maternal death is heart disease. Women present with central chest pain, breathlessness, pain going down your arm, symptoms which, apologies, if you were a middle-aged or older man, would immediately be picked up as heart disease. And yet, because women are pregnant, it is assumed that it is a symptom due to pregnancy. And we often see that the care women receive, particularly from inexperienced or junior staff, when they're pregnant, when they're admitted to acute medical settings, for example, it is assumed that many of their symptoms are due to pregnancy, as opposed to be due to really quite concerning physical illness. And that's why for me, we do, with maternity safety, have to think more broadly than just maternity services.
Taiwo?
Thank you, Chair. I was just going to ask about maternal suicide in the afterbirth of birth, and something that you've spoken quite a lot about today. Can you just tell us more about what causes it? Because I believe that it's not really spoken enough about, and whether or not your research shows that women from Black, Asian or minority ethnic backgrounds are in a higher risk of committing suicide post-birth.
You're absolutely right. It's one of those taboo subjects that is not talked about as much as it should be. So again, the data do not show that Black or women who are from Black or other aggregated ethnic minority groups have a higher risk of suicide. But what they do show is that women present frequently with symptoms which again are dismissed or normalized. And again, for me, it is a bias, a structural bias in our systems. Women will present to many different health professionals. They might present to emergency department. They might present to their GP, and nobody sees the overall pattern and recognizes the distress women are in. So the women who die by suicide the vast majority will have sought help on multiple occasions, but nobody's recognised that overall pattern because there isn't that holistic care. We've got very siloed systems and women's voices are not necessarily heard, and which is why we have raised on several occasions that repeated presentation has to be a red flag, and there should be an emphasis on making a diagnosis rather than simply excluding diagnoses.
Thank you.
Thank you. Could I just follow up and ask you, Professor Knight, about whether continuity of carer could have a big role in addressing some of these issues, because it's an issue that I know that Professor Dunkley-Bent is looking to introduce, I think, for 3/4 of minority ethnic women by the end of the Parliament, from memory. But do you think that has a role to play if you have a single team of midwives who you meet ahead of birth, during birth and post-birth?
So there's absolutely no doubt for me that if you have a trusted relationship with your midwife or group of midwives or health professionals, so that you feel able to disclose when you're concerned about symptoms, that you feel listened to when you are reporting your symptoms, that will make a difference. I think the crucial thing for me is that it has to be the right group. That group of midwives have to have the right expertise. And I think it would be useful to get Chloe and Tanuka's thoughts on this, because if it's the wrong midwife or the wrong group of midwives, that is not going to make the difference. And my concern, because the women who die have complex and multiple problems, it really does have to be a group, a team with the right expertise. And for me, many of those discussions about what is the right type of care for you need to be taking place at the very beginning of pregnancy, or indeed before pregnancy. So it can't be that one size fits all.
Thank you. Let me bring in Tanuki on that point. How much would it help you if you had a single team of midwives who are looking after you pre, during and post-birth?
I think continuity of carer would be a fantastic model if it was definitely something that could be implemented, as the NHS have said, because I know definitely in my case, and with the fact that my preeclampsia wasn't picked up on in a timely manner, if I was seeing the same midwife or the same 2 midwives, that it wouldn't have got to the stage where it got to, and that honestly, that is the truth. But I do echo Professor Mariam's believes in that it does have to be the right midwife and set of midwives, because if, let's say for instance, they don't know about the statistics when it comes to Black women especially, there may be other factors which might actually just mean that it's just this all of the same, if that makes sense. And I think, I do think it's important that there's more awareness raising of the outcomes, the poor outcomes for Black women first, and that will then help the midwives sort of do what they need to do to make sure that the women are the centre of their care and they're getting the best care at the end of the day. But yeah, I echo everything that Professor Mariam Knight had said. I think it'd be a great model if it could be implemented, but it has to be the right midwives.
And can I just ask you one more question? We're shortly going to hear from Donna Ockenden, who did a report into the baby deaths at Shrewsbury and Telford Trust, and one of the factors she identified was that mothers were sometimes put under pressure not to have C-sections and to have so-called natural births. Is that something that you've come across in your network at all, that people were sort of being steered away from C-sections?
So, unfortunately, I can't speak on that because I haven't heard much about the review, and that's not my area of expertise. So, unfortunately, I couldn't say that. But what I would like to point out is that when it comes to, again, just going back to the evidence that we submitted, we are seeing that women are just not being given the right information. So, yeah, that's as far as I can say, but thank you.
I don't know if we still have Chloe online, whether you wanted to add anything finally to wrap up, if you're there.
Yes, sorry, just my lighting is awful, sorry.
That's all right.
I want to go back to the point on continuity of care. I do think continuity of care, it's a great kind of model if it works well, just like Marilyn and Tanuka said. But from my own pregnancy experience, I never had continuity care with my first son, and that experience was so beautiful. It was a positive birth, only because when I was in labour, the midwife who I had gave me personalised care. She really got to know me, and I only known her for a short amount of time because I gave birth within 3 hours of knowing her. But she actually built a rapport with me. She got to know me, who I was, and we built that great relationship which in return allowed me to have that great pregnancy and birth experience. I had a very good vaginal birth because of the relationship I had with that midwife at that short amount of time. Now with continuity care, it's all well and good, but if you have one midwife or two midwives during a pregnancy, does that midwife now deliver a baby? And that's where continuing care sometimes may not work, because that midwife might not be there at the end, but you need her at that crucial point when you get to the end. Talking about, are women pushed to have a C-section? A lot of women I've come across are not pushed to have a C-section. Majority of them, there's a lady I was supporting not so long ago, she was actually pushed to have a vaginal birth. And because the midwife was really wanted her to have a vaginal birth, she was really pushing her to have a vaginal birth, she ended up having a C-section because the pressure was too much for her. And she was like, I can't do it. And, the midwife was like, you can do it, just do it. But it was so aggressive that it just threw her off, and she was like, I can't do this no more. And she felt like a failure because she felt like she let the midwife down. So, yeah.
Thank you. Well, that's a very powerful testimony. And thank you to both you and Tanuka for joining us this morning. We really appreciate that. Thank you to Professors Kurichuk and Knight for joining us from Oxford University, and really appreciate you giving up your time. We're now going to move on to the second panel this morning, where we just have one witness, who is Donna Ockenden, who's been conducting an independent inquiry into baby deaths at Shrewsbury and Telford Trust, which was actually something I commissioned her to do when I was Health Secretary. And that initial report was published last week, as everyone knows. Thank you very much for joining us, Donna Ockenden, and thank you for the excellent work that you've done and your team have done. And there's clearly, even though it's only an interim report, a huge amount of lessons that need to be learned. I wondered if I could just start with one in particular, which is, I think, the thing that will have shocked a lot of people when you published that report last week, which was why it took so long for these issues to come to light. I mean, they really go back decades, and knowing, as we know now, that I wouldn't have asked you to do this report in the first place if it hadn't been for the campaigning of Rhiannon Davis, Richard Stanton, Kaylee and Colin Griffiths after their tragedies. I just wondered, what do you think was going on? Were the mistakes that led to so many deaths deliberately covered up, or was something else happening?
Good morning, Mr. Hampton, and thank you very much for asking me to join you today. I think the one issue that stands out above everything else is a failure to listen to families. As you know, the Secretary of State cohort starts in the year 2000 and our cases run up to 2019. Basically, bereaved parents pushed for the original 23 cohort to be instigated, and it was their efforts working with you that led to that. But within that cohort and earlier than that, we've come across a lot of families who tried really hard to get the system, the trust, to listen to them. And they carry on their shoulders now a huge amount of guilt because they feel that they failed to get the system to listen to them.
So I'm just trying to get a sense of scale, but you've just looked at 250 cases so far. How many preventable baby deaths do you think there were? I mean, you can't give an exact number, but what sort of scale are we talking about?
So I can only comment on the 250 cases that my independent clinical review team have looked at to date, and those findings are, very clear in our first report. We've got an awful lot more work to do, so I would have to ask you to bear with us while we complete that. But the focus, I think, is and should be on the learning that already comes out of this first report.
But of those 250 cases, what sort of scale, how many, were there 250 preventable baby deaths?
No, so the 250 cases are a selection across the cohorts, so from 2000 to 2019. So they mustn't be treated as more than an indication. And as you'll remember from the original Secretary of State cohort, there are 5 key categories. There are stillbirths, there are neonatal deaths, there are maternal deaths, there are brain damages, and then there are a category that we call severe harm to mothers or babies. So at this stage, because we know that Shropshire it's a small population and everyone knows each other, we've been very careful not to say, well, there are X baby deaths, there are X of this, there are Y of that. And I think until we publish the final report, what we should acknowledge is those 5 key categories, all of them very, very serious indeed.
Okay, I understand your reluctance when you're still in the middle of the inquiry, but I just really wanted to ask about the culture in the trust. I mean, you talked about the continual changes of leadership, I think 8 chief executives in the last 10 years, but and you talked about not listening to mothers, but are you saying that these tragedies won't have been noticed by the trust? I mean, obviously if they'd listened to the mothers, they would have reacted differently, but are you saying they really didn't know what was happening, or that they did know but they chose not to take action?
So I think, and I can't stress it enough, listening or not listening to families is absolutely key. We know that many, many families tried over many years to get the trust structure, and that's midwifery, obstetrics, general management, and to executive level, to listen. And we've seen lots of examples already in the 250 really dismissive letters, very unkind letters. And, what was picked up very accurately in the media, and families themselves said it from Thursday onwards, there was also a culture of, well, this is your fault to the mother. If you hadn't done X, then your baby may have lived. So I think that's one key issue, not only not listening, but blaming mothers, which, again, mothers and fathers will tell you they've carried that guilt for years. There was also a tendency not to investigate. So there's been, I've been a head of midwifery since 1999. I clearly remember the start of an incident review process in the very early 2000s. It's when I joined Portsmouth, 2001. We were absolutely starting to investigate when things didn't go, as they should have. For a very long time, the Trust had their own mechanism. They called them HRCRs, which I've never come across anywhere else in the country, high-risk case review. So they didn't follow national guidance. And what we found, and bearing in mind my team are almost all entirely clinical, most of the week they spend out doing shifts on labour wards, antenatal clinics and whatever. What we found is that when they did investigate, if they did investigate, they often just hung their hat on the wrong hook, so to speak. They picked something that certainly wasn't the root cause, and they got diverted, so they failed to learn. And another issue that's coming up, because the Trust have now shared with us a vast amount of documentation, they've been really, really helpful in that, is we noticed that until a complaint came in, or until litigation was commenced, the initial Trust review simply didn't happen. So I think it's not one issue. It's not that they try to sweep things under the carpet. It's not that they just didn't listen to families. There were multifaceted things going on, and I have to say, across all professions.
Now, what was very striking, final thing from me, and then I'll bring in my colleagues, is that you made recommendations at this very early stage, not just for the Trust, but for the whole of the NHS. And I just wondered, what's your basis for thinking that this is not a one-off issue, but there are lessons here immediately that need to be learned right away for maternity services across the NHS?
So we were tasked by the Minister of State back in the summer to get out some early learning. She personally asked me, by the end of this calendar year, please, if it's available, can you get out learning for the Trust, and also please look to see if there is potential learning for the wider system. So again, as we were doing our work over the summer and into the autumn, we very clearly identified 27 local actions for learning for the Trust itself. But again, taking into account that my team is entirely clinically focused, they're there day in, day out, in their trusts, in their clinics, there started to be a realisation that although this was a review of the Shrewsbury and Telford Hospital NHS Trust, but it would make good sense for other trusts to start looking at issues to ensure that actually what was happening at Shrewsbury and Telford was not happening in their own trust. So think of it as a preventative action. Go away and look at the way you run your labour wards. Go away and look at the systems that you might have in place for risk assessment. So it was a preventative issue. Go away, please, and examine, consider what we're saying here. And I am pleased to say, you may be aware that a letter went out late last night to all Trust Chief Execs, Chairs and CCGs, telling them, reminding them about our immediate and essential actions and asking for some pretty immediate action on those immediate actions, I think by the 21st of December. So we're really pleased about that.
Thank you. Laura Trott.
Thank you, Chair, and thank you, Ms Ockenden, for this incredibly important review. One of the things we've been covering and has come up as part of this inquiry is the prevalence of ideology over views on how women should give birth and the impact that that has had on maternity safety. Now, I noted as part of your interim review findings that the caesarean section rate in the Shrewsbury and Telford Hospital NHS Trust was much lower than the rest of the country. Can you give your insights on the impact that that had overall on maternity safety and some of the drivers behind that you found from your initial findings?
Good morning, and thank you for that question. So it's very clear from our report that yes, caesarean section rates were considerably lower at the Shrewsbury and Telford Hospital when compared to trusts locally, trusts in the region and trusts across England. They're from NHS statistics, and that's really clear. Again, what I would say, this is a multi-professional issue. So we have spoken to hundreds of women who have said to us they felt pressured to have a normal birth. My clinical team have said that they've seen examples of even in situations where a normal birth in their own hospitals would be contraindicated. There were examples of women being pressured to have normal birth. But this came, and I need to be really clear here, this came from across the professions. This came from obstetricians, and this came from midwives. It wasn't solely a midwifery issue. We will be writing more about it in our next report because it's something that we need to explore. But the issues that happened at the Shrewsbury and Telford Trust were multi-professional in nature. It wasn't one profession battling against another. It was across those key professions.
You use the term there, normal birth. Is this something that you think is outdated and now needs to be changed? Because obviously normal is, the right choice for women is the safest choice. Do you think we need to look again at whether we should be using the terminology normal birth at all?
So again, I would base everything that I say and do on what families have told me. And again, I've met hundreds of families face to face in Shrewsbury, and the very clear steer from those mothers and their extended families is safe birth. They want a birth that is safe. At the end of it, they are well and in good health, and their baby is well and in good health. So for me and my team, and for the mothers and fathers who've contributed to this review today, it's about a safe birth.
Absolutely. And do you think that there is more that, and this might be something that you're covering as part of your forthcoming further review, that the NHS needs to do in terms of looking at C-section rates and how they monitor them overall, and also in terms of the information that women are given about the safety of various choices? I know this is something that you cover as part of your interim review. Are there specific recommendations that you have around that you'd like to discuss with the committee?
So I think what we've raised in our first report, in both the local actions for learning and the immediate and essential actions, is the issue of informed choice, truly informed choice, so that when women are making choices about place of birth and mode of birth, they actually make the decision based on accurate information. And that's something that we know the Trust is going to be working hard on, because they've given us a commitment that they will be actioning the 27 local actions for learning, plus now the system, as a result of the letter to chief execs and chairs last night.
Right, and do you think that that is a problem for the NHS more broadly in terms of the information that women are given about their birth choices and the various safety of the various options?
So I think what we've asked for in the immediate and essential actions is that all trusts go away and look at this. And in the letter that was sent last night, I think they cite the Chelsea and Westminster Trust as an example of good practice. So again, there are trusts, and we need to stress that there are trusts that are doing incredibly well in terms of the safety and quality of maternity services, and we mustn't lose sight of that. But the whole thrust around the immediate and essential actions was, please can all trusts look at this report and make sure that their services are as safe as they should be.
Thank you very much.
Thank you.
Thank you. Neil Hanvey.
Thank you, Chair. Good morning, Ms. Ockenden. Thank you for the report and for your input so far. I wanted to begin to explore some of the recommendations that you have put forward. But before I do, I was interested in some of the comments you just made, particularly about risk management and reporting mechanisms. And those are pretty fundamental tools to monitor and manage clinical safety in a whole range of settings. Am I correct in understanding that you found that those systems either weren't in place or just did not get used effectively?
Yeah, you're absolutely correct. In a number of the 250 cases that we've looked at so far, my doctors and midwives, who are everyday doctors and midwives in 12 trusts across England, picked up quite quickly that the root cause in a particular case simply hadn't been picked up by the local system in Shrewsbury and Telford.
Okay, and so there was no, I assume from that, if risks are not being reported, then there's no observation of patterns that begin to emerge. Was there not a concern at board level that those data, which are fundamental to any NHS organisation, were not being generated?
So again, we need to, if you remember, in chapter 3 of the report, bearing in mind this is the first report and we've still got more to do,
yeah.
Mr. Hunt says we do draw attention to the turnover, the churn at board level, at chief exec level, at non-exec director level. And that's something we do need to look at in the second report. It may well have been a factor. It may well have been a factor.
That's great, thank you. I wanted to now ask you a bit about what you envisage the managing complex pregnancy aspect of the report in terms of how organisations are going to start to work collectively, and whether you see this as a clinical network type model, and how review, peer review and the likes will happen within those networks.
Okay, so the first thing we say is that all complex women should have a consultant lead. And in our review of the 250 cases, we found a number of cases where either women remained under midwifery care, or where they were referred on to consultant specialists, perhaps in cardiology, epilepsy, where they were then seen by junior doctors. So, a failure of consultant oversight there. And then when women should have been referred out to regional centres, they were kept in-house at the trust. So there were a number of failings that my clinical team picked up on. So what we're saying is first there needs to be local action. So trusts need to be assured that with women who are complex, they get the right oversight within a trust. So whether that's a consultant obstetrician leading on their plan of care, a consultant anaesthetist, really important member of the maternity team involved at the right time, not walking in an emergency when there's never been an anaesthetic plan for a lady. And then, and I know, for example, that London is making some really good progress on this, the ability for trust to work as part of a network of maternal medicine centres. So we know that not every, you wouldn't expect in a district general hospital, for there to be all of the specialties that women in our population might need. But we're all talking virtually today. Ordinarily, I would have been sitting up with you in London. We've got much better, at virtual consultations. So it should be relatively easy for this kind of arrangement to be put in place. And we do think, as I said in the report, it's an urgent national priority now for all women to be able to access the help that they need from the specialists that are out there.
And the risk assessment that you envisage happening throughout pregnancy, do you see that as a vehicle to drive higher risk women into the specialist centres? Is that something that you see that being able to facilitate?
Yeah, so that could work both ways. An antenatal checkup should be a risk assessment. So at every antenatal contact, whether that's with a community midwife, a hospital midwife, an obstetrician, a GP, whoever it is in the maternity team that is seeing that woman, should monitor risk. And it may well be that then what happens is the care plan stays exactly the same. The woman remains low risk, or her medical condition that she may have come into pregnancy with is well managed. And that's fine, that's a reassurance. But equally, then there needs to be a decision as to whether the woman's care needs to be escalated to a consultant obstetrician, whether she needs to see a consultant anaesthetist in her pregnancy, or indeed whether the skills are not present within that hospital and specialist help needs to be sought from within the region.
Okay. Can I ask one final question, Chair? What barriers do you envisage to making your recommendations a reality? And if you were to ask for a wish list of 2 or 3 particular aspects of support, what would they be?
So I'm really pleased. I was up very late last night. I'm really so delighted that the national system, has now written out to all chief executives and chairs and CCGs, highlighting the key issues. So there are the 7 immediate and essential actions, and what has been highlighted from within them, because there are subsections, are the key issues that could be acted upon now. And risk assessment is one of them. Listening to women's voices is another one of them. So I do feel confident that, it's only Tuesday today, and I'm speaking, to this committee, giving evidence to this committee. A letter's already gone out, across the system. I do feel confident at this stage that everyone has understood the seriousness of the issues both raised in Shrewsbury and Telford, and the absolute need for the wider system to look at everything that we are saying.
Fantastic. Thank you ever so much for all the fantastic work you're doing. Well done.
Thank you. Thank you.
Rosie Cooper.
Thank you, Chair. I'd like to thank you for all the valuable work that you're doing. And just to go on the point you just made about confidence that the system is listening, I suppose I want to say that Robert Francis and the eons of people who've made recommendations following inquiries have always hoped that things would improve. And we haven't really seen that almost generation of improvement that we needed. In this, your 7 immediate actions and key recommendations, they're really common sense, they're not earth-shattering, they should have been happening anyway. Here, you indicated that the board oversight wasn't good, the board and management, were not listening to patients. So my question relates to the higher deafness, the deafness of regulators, who I would say are missing in action in most of these inquiries. The CQC, the Department of Health itself, NHSEI as it is now, or the TDA as it was. And then what is the point of staff and patient surveys? We've invested a lot of time and money in getting these things on the table from previous inquiries, and yet they've all failed here again as well. So how can you feel more confident that we can wake up the regulators? They cost us a lot of money, and make this work for patients.
So that's a really good question. Essentially, this first report is about immediate actions for learning, and you can see that in chapter 3 of the report there is a brief outline. It's only a few pages of the things that we will be considering in more detail. We talk about the role of the CCGs, the board, the CQC, statutory supervision of midwifery that was around until 2017. So please be assured that we will leave no stone unturned in assessing the role of all of these systems. But what we felt in terms of getting real clinical actions out onto the ground before Christmas, that's been our main focus in this first report. But please be assured that all of this is underway, and we won't shirk from our responsibilities in calling this out if needed.
That is really good news. So Bill Kirkup's doing another inquiry. So between you, I only hope and pray that we have a major influence on the system. Can I just ask you one further question? A clinical question. We hear a lot about a team of midwives. The team of right midwives will make a huge difference to the care of mothers. And it is very appealing, but I was chair of a Liverpool Women's Hospital in the late 90s, and I didn't manage to get in to ask Professor Knight whether the model had been costed, both in terms of, it's not a new idea because Baroness Cumberledge actually promoted this in the 90s. And my belief is that due to huge extra costs, and I don't mean a few thousand, a few 100,000, we're talking millions, and the lack of staffing, this never got off the ground. Do you think that the model's been costed and it could work today? Do we have the money and do we have the staffing to do it?
So that's not something that we've focused on in this report so far. Obviously, we've looked at the 250 cases, and this issue of continuity of carer, I think you're describing, we used to call it team midwifery, as you say, in former times, didn't come up as an issue that would have influenced the women's care. So it didn't come up as, if only we'd had that, it would have made a difference. Now, I was a head of midwifery from 99 until 2014, so a long time, and I do recognise, the workforce constraints and difficulties. And so I think if I was to ask for one thing, it would be multi-professional working and actually two things, and the continual risk assessment of women throughout pregnancy, rather than hang my hat on one particular model.
Thank you very much.
Thank you.
Thank you. And finally, Sarah Owen.
Thank you, Chair, and thank you, Ms Ockenden. You've talked a lot about enabling women to make informed choices, and women need to be informed free from ideological bias. So when discussing my mode of birth earlier this year, I was given a list of risks when it came to a C-section, but I really had to push and question what the risks were for a vaginal birth. Why do you think there is an ideological preference for non-assisted vaginal births from some maternity teams, and how ingrained do you think that ideology is?
So we saw, and it's very clear in our report, this very big difference in the C-section rate between the Shrewsbury and Telford Trust, other local and regional trusts, and across England. We need to look at this in more detail in our second report, but what was very clear was this was a multi-professional effort. So, we know that the obstetricians were very much leading the way in Shrewsbury and Telford in terms of the push for normal birth. A number of my obstetricians have commented that, in some of the scenarios where normal birth, if you can call it that, was achieved, they are very, I've got very, very experienced obstetricians on my team, and they'd have said, absolutely not. This, under my watch, on my shift, on my labour ward, this would not have happened. So I think it's really important to say that at this trust, it was a multi-professional, not just midwifery-led focus on normal birth at pretty much any cost. And it is also very clear, I think, in our report that there were times, there were occasions, there were cases when, had a baby been delivered by a caesarean section, the outcome may well have been better and almost certainly would have been safer.
Thank you. I just wanted to dig a little deeper, because that doesn't just come about organically. Why is it, do you think, that ideological bias towards vaginal birth was so embedded and so widespread?
So we've still got an awful lot of evidence to review, which will be part of the second report. What we've managed to say to date in this first report is that there were a number of cases where caesarean section should have been used earlier, and had it been used earlier, the outcome for mothers and babies would have been better, would have been safer. So the Trust have worked really hard to amass a vast amount of documentation that we've received in early November, and we'll be making our way through that. And what we can promise you is that we will be looking at this in much greater depth in the second report later in 2021.
Thank you.
Thank you.
Thank you. Barbara Keeley.
Thank you, Chair. It's just a follow-on from what Sarah has just been asking. I just wonder if you believe it is possible to change that deeply ingrained culture across professions, as you said, where the view is that they know more than the woman giving birth, how she should give birth, as indicated by the use of that term that we've been discussing, normal birth. Clearly, you can point to trusts where it is being done well, but how possible do you think it is to change that? Because we've heard earlier, when we were looking at the example of black mothers, where maternal mortality and baby deaths were much higher, that a mother felt she had let the midwife down. I mean, where are we with care when somebody feels they let the midwife down from having, through having a C-section rather than a vaginal delivery?
So I did just catch the tail end of that conversation, and it's, having been in and around maternity services and women and children's divisions now for over 30 years, that is such a sad story to hear. To my mind, it has to be about women being equal partners in their care. And I know that there are a lot of trusts, doing that very, very well. And I think we need to call it out for what it is, which is unacceptable if women and their families, because I've met countless husbands and partners in tears because they felt they let the system down, as well, for not playing a strong enough role. I think we need to call it out for what it is, that childbirth and the arrival of a new baby should be the most joyous event in a family's life, and it's simply unacceptable if what we leave along the way are instead broken families and women who carry guilt on their shoulders for many, many years. And I will be the strongest advocate for women that I can be, that I hope I've been throughout my career, but I'll continue to speak out on this for as long as is necessary.
Okay, thank you.
Thank you.
Thank you. Just a final question from me. How much would it have helped the families you've spoken to if their child's death had been investigated independently right from the outset?
So I think what I would say to that is, again, I refer to the fact that I've been in and around maternity services, for about 30 odd years. And I've got very clear memories of very effective investigations done locally with external expertise called in as required. Certainly, in my days in Portsmouth, we were doing that from the early 2000s onwards. I think, Mr. Hunt, this is about leadership. I absolutely treasured my role as head of midwifery and divisional director, and I took huge personal responsibility in ensuring that if things went wrong, and they can go wrong sometimes in the very best of services, that families felt satisfied that any review or investigation that was done was of the highest standard. So I think this all goes back to leadership locally within the trust, the ability of the head of service, so the head of midwifery, to talk to and interact with the board on an as required basis. And I never came across any barriers to talking to my boards and getting them to listen. And then the families, I think what is really important is that if something goes wrong, what we want is for families then to have confidence to be able to go back to their local services to continue to receive healthcare. So I think there's got to be something about skilling up local and regional services to make sure that they do investigate appropriately and they do then build those relationships with families.
Thank you very much. Well, that concludes this panel, and Donna Ockenden, thank you very much for joining us, and thank you again for the hard work that you've done and that your team have done to get to this very important interim report that you published last week. And as you say, it's very encouraging that the message has now gone out to the whole NHS about lessons that need to be learnt immediately. So thank you very much indeed for joining us, enormously appreciated. And I'm now going to move on to our final panel this morning, and I want to welcome Dr. Edward Morris, who is President of the Royal College of Obstetricians and Gynecologists, Jill Walton, who is Chief Executive of the Royal College of Midwives, and alongside them is Professor Gordon Smith from Cambridge University, who's been doing important research into whether we should be doing additional ultrasound screening to check for breached births, where babies' heads are in the wrong position. So I want to start, if I may, by asking Dr. Morris and Jill Walton about the government's target to halve neonatal injury and death by 2025. It's a very important target, and I'd like to get a sense as to whether you think that we are on track. As I understand the latest figures, we've reduced stillbirths by a quarter from 2010 rates, and neonatal deaths by 23% from 2010 levels, but there's still a long way to go. So if I could start with you, Dr. Morris, are you optimistic that we can get there, or is there things that are there things we should be doing that we're not?
Thank you, Chair. Yes, I completely agree with you that we have made progress, and that's great news indeed that has happened. However, as you say, I really feel, as does this profession, that there is much more work to be done. And I think to do that, we need to address a lot of what we've talked about this morning so far. And I think there are areas where significant improvement can be made. And I think this needs a team approach supported by the government to invest more in safe maternity care. I think that's where I'll start my answer, but I'm very happy to continue perhaps after Jill.
Jill?
Hello, good morning, Chair, and everybody. Thank you very much for that question. I think there has been progress made, and there is a long way to go. And I think what the Ockenden report has shown us, that we need to speed up, we need to develop system changes at pace, which includes the softer stuff, which is the most important stuff, which is around behaviours, listening to women, focusing on the things that make the biggest difference. And that has to be the multi-professional working together, learning together, training, and fundamentally based on enough money to support maternity services. I think we've been saying for a long time that maternity services are underfunded. They're underfunded and they still are subject to cuts every year. And so some of the things that we believe are the essential components of safe maternity care are affected year after year. So I think there's still a long way to go. And I think the report we've just heard about needs to make us all step up and gather pace to make these changes much more quickly than they've been happening. I think the other thing is you will see the array of things that have been done over the last 3 to 5 years. And in maternity services, for those health professionals working in maternity services, some of those things are very confusing. There's lots of action. And the trouble is that then leads to a lack of focus sometimes about the things that really work. So I think one of the things we would say is be really clear about what does work, pull all those things together so it's really clear and supportive for those leaders in maternity services and those systems to implement those changes more quickly. Thank you.
I think I just want to dig a bit deeper on what needs to happen in terms of staffing levels, because you talked about cuts and there are still people who feel there are shortages of the necessary skilled people that are needed. One suggestion is that we should specify nationally the workforce requirements necessary to deliver a safe birth, and then we should make sure that every single maternity unit has those numbers. Is that an approach that you would take? Let's carry on with you, Jill Walton, and then I'll come back to Dr. Morris.
Yes, that is an approach that we should take. Birth Rate Plus is the midwifery tool that you may have heard of. We have just done a further analysis with Birth Rate Plus on 50 trusts, and sadly we're still 3,000 midwives short. Some of that is because women's needs are more complicated, and so there's definitely more midwives needed. But it's not just about midwives, it's also about maternity support workers who are an essential part of the maternity team. And it's about obstetricians, anaesthetists, and neonatal teams, perinatal mental health teams. You know, the whole workforce that is required to safely deliver care to women needs to be appropriately funded. We've just also done a survey, and I know it's during the pandemic, so during COVID, and we asked midwives, how safe do you feel delivering care? And 80% of them said they currently don't feel safe in terms of the right numbers of staff to deliver safe care all of the time. And that's really shocking. And we know that that is not right for women. It is not right for women to have a maternity service that doesn't have an appropriately funded workforce. I will always add the good things, and that is that we have seen an increase in the number of midwifery training places, and that was to try and catch up with the 3,000 short we had 3 years ago. But we have to keep on top of that. And whilst there may be smaller numbers of vacancies in maternity services at the moment, actually the funded establishments for those services are not right. I welcome the letter that came out last night from NHSE to trusts to very carefully look at their workforce numbers and with a tight timescale. And the Royal College of Midwives will absolutely support those trusts to do that piece of work.
Thank you. Ed Morris.
Yes, following on from what Jill said, I completely agree with everything that she said. And when we look at obstetrics as part of the multi-professional team that we've heard so much about this morning from both Chloe and Tanuka and also from Donna, it is vital that we have the right numbers of doctors and midwives working side by side. In obstetrics at the moment, if we look at our training grades, we know that every single unit in the country has gaps in the rota of the junior doctors and the senior trainees who are delivering service, which I think shows that we do have a significant problem in staffing those rotas. When we look at consultant obstetricians, we don't know yet exactly how many more staff that we need, but if we're going to expand the work that consultants do along the lines of Donna's recommendations in the letter last night that we welcome, we may well need an expansion in our consultant workforce of somewhere around 20%. Now that would need training and would need considerable efforts to encourage more doctors into the specialty. So with obstetrics, I think that's where we need to go in terms of expanding the staff. But the team goes wider than that. As Jill said, it is working with midwives. It's working day by day as a team. And we know that teams, when they work under pressure, are less able to work efficiently. And there are loads of research studies that demonstrate that teams under pressure, they don't have time to do a high quality level of work. But importantly, they don't have enough time to take time off work to go and train. They're trying to fill the rota day in, day out. They don't get time to go away from their unit and do team training. Obstetrics, midwifery, maternity is a very, very high pressure specialty. And quite often an emergency will happen quickly, it'll happen unpredictably, and the survival of the woman or the baby will depend on a team being able to get into gear quickly and recognise how to manage that. And those are practice drills. It sounds very military. That's because in some cases it needs to be. People need to be able to respond extremely quickly. So if units are under pressure and understaffed, as Jill has said, then the teams don't get time to train properly. And that's one of the areas where we feel that steadily over the years, that loss of team identity and the ability of a team to work together has been lost.
Thank you. Now, I've got lots of colleagues who want to come in, but I've just got a couple more questions I want to ask you about what we've heard this morning so far. We just heard Donna Ockenden describe a culture at Shrewsbury and Telford as normal births at any cost. Do you accept that that, first of all, was a serious cultural problem at Shrewsbury and Telford? And do you think that we still have that problem in other parts of the NHS? Let me go to Jill Walton first.
Thank you. And obviously I heard Donna's answer as well about those cases being a wider problem across the whole multi-professional team. I think it's a really complex issue, the issue of, I think, first of all, normal birth ideology at any cost, and normal birth as the physiology of normal birth, which understanding normal physiology is really important. I think for me, the important thing is that it's not about promoting normal birth as the best outcome. It is really important to understand the woman's values, her needs, how she understands the evidence underpinning the care and the choices that she has.
Sorry, can I just cut you? I just really want to understand, first of all, do you accept that normal birth was promoted like an ideology at Shrewsbury and Telford? Because that's what Donna Ockenden said. I just want to ask you whether you accept what she said, which is that that was an issue.
It does sound like it was.
Okay. And do you think that there may be a problem in other parts of the NHS as well?
I think it's changing, and I think it's really important that all the teams work together with women at the centre of care, and they don't promote one type of birth over another. One of the things that Eddie and I are talking about a lot now is how do the two colleges come together with one voice in supporting good birth.
Okay,
good birth through the eyes of women, and it's the moving on from that is really important.
Thank you. Let me ask Ed Morris on that one, if I may.
Yeah, it certainly seems from what Donna was talking about that in Shrewsbury and Telford, a culture like that existed. And do we know that that's happening around the country completely? I don't think we do. We know there are some excellent units around the country that have extremely good rates of intervention and good rates of satisfaction and safe deliveries. Obstetricians are part of a team that support women to have a birth that is safe for them and their baby. In the UK, only about 40% of women in this country actually give birth without any form of intervention. And that's mainly because birth is unpredictable, complications can arise, and decisions made should be very much made with the complete involvement of the mother. She should feel fully informed. She should be part of the process, very definitely, ensure that she feels comfortable about the choices that she has made. So as Jill said, I think our role as the colleges, working with the right partners, is to make sure that this culture, if it exists, is wiped out. We have, as I think Donna said in her answer, that I think a lot of this stems from leadership. If the leaders stand side by side and don't tolerate cultures like that, then it can only filter down through the system. And one of our concerns that Jill and I have had frequently about centres that do not seem to be working well or in difficulty is the fact that they don't necessarily seem to have the right support at board level, which one of the members of the committee concentrated on before. And I think that's really important. Jill and I feel very strongly that maternity needs to be represented at the board. It needs to have a sound voice on the board so it does not get ignored.
Thank you. And just one final question from me. We've heard a lot this morning about how difficult it was for families to speak out and they weren't listened to at crucial moments, and that was really the heart of the problem, I think, according to Donna Ockenden. But can I ask you, as representatives of your respective professions, is it sometimes too hard for people inside a hospital, inside a maternity unit, to speak out when something goes wrong, because they're worried of recriminations, they're worried that people might not understand the difference between an ordinary human mistake and clinical negligence? And are there things that we can do? Do the HSIB investigations help on this? What do you feel? Let me start again with you, Jill Walton, if I may, about whether there's more we could do to make it easier for people to speak openly when tragedies happen.
Okay, I think it's absolutely true that staff are not working in a blame-free environment. And I think that we've got a lot to do to create transparent cultures where people feel really well supported to speak up when things aren't right. I think that listening to everybody, to women, to staff, to have that high level representation at board level is absolutely key. For people, for senior leaders to be able to go to the board and into the system to very truthfully talk about what's going on is really important. You mentioned about HSIB, and I think HSIB was a good idea. So, you know, having a system of investigation that was consistent across the country and showing the way in terms of involving women and their families in that process was really excellent, because some services were doing it really well and some services weren't. So in terms of providing that level playing field across maternity services has been good. But I think we have had some concerns about the speed of some of those investigations, maybe some of the quality of the thematic reports that have come out. I think as well, our members have told us that when you have an external team coming in and being part of the investigation process, you lose some of the local learning. And that's quite key, because systems and services are all slightly different. And so some of that local learning has been lost. The good services had already, before HSIB, started to involve neighbouring trusts into reviewing and looking at some of the very serious incidents, so they weren't marking their own homework. And I think that is quite a good model, and I think it's one of the things that Donna is suggesting, that not just the learning from the local maternity service, but across the system is really quite important. So I think on balance, HSIB has got some really good things, but I'm not sure it is the answer.
Okay.
I'm sure Eddie can answer some of that.
Dr. Morris.
Thank you. I agree. I think there is more to do to listen, or to enable staff to listen more. Let me give you an example, Chair. You'll recall the RCOG project, Each Baby Counts. Now that was run as a confidential inquiry. So trusts were able to give us the information about every brain damaged baby or stillbirth towards term pregnancy. And we got every single detail about those cases from 100% of the trusts in the UK. And that enabled us to delve deeply. And that shows that if you're able to get the full information, you can learn an awful lot more. Like Donna was describing in her evidence this morning, where she's worked, she works in a unit where there is high quality local investigation, where people really learn from what happened. There is true value in a local unit doing an internal investigation to look into what went wrong. And if you do that regularly and you listen to people, you value them, but you still have the mother at the centre of that investigation, you end up with a very high quality look into what went wrong and the learning from it. With HSIB, I think HSIB has worked extremely well in some areas, as Jill said, and we largely agree on this. They've investigated over 1,000 cases and published some thematic reports on just over 300 in the time since they've existed. Their independence, I think, has very much been valued, and certainly by families. I think the family involvement and the listening to families has been critical with the success of HSIB. But we do feel, as Jill said, there has been some loss of focus in the output of HSIB, and I feel that the output needs to be refocused to allow trusts some ownership of what went wrong, but it still needs some national oversight and with strong family focus so that those issues can be addressed.
Thank you very much. And now James Davis is going to ask a few questions to Professor Gordon Smith, who is joining us to talk about the issue of scans.
Yes, Professor Smith, thank you. I understand you have an interest in novel approaches to preventing adverse outcomes, and yes, the idea of a third scan in particular beyond the 20-week anatomy scan. I wondered if you could outline the findings of your research in that area, please.
Yeah, so we've looked, there's a number of things that can be assessed in a late pregnancy scan, and one of the things we've really focused on is a scan near term. Term is, the due dates are in 40 weeks. We think about a scan at 36 weeks, is trying to really stratify women for risk as they're making plans around location and type of birth. And so we evaluated over 4,000 women having first pregnancies, where we performed ultrasound scans and then followed the natural history of the pregnancy. And we've also combined that with some health economic analysis. I mean, to me, there's one kind of open goal at the moment, and that is the presentation of the baby. So midwives routinely at the moment perform palpation to determine whether the baby's head first or otherwise. But what we know from research is that anybody doing palpation detects about 50 to 70% of non-cephalic presentation, and they miss the remainder. And in those cases where the diagnosis isn't made, the woman then loses the opportunity to have interventions. So the baby we can attempt to turn the baby using external cephalic version, or they can have a sort of discussion around the plans for planned cesarean section or planned vaginal breech birth. It's one of these situations where you really want to know the information before you go into the situation. But what happens is quite large numbers of women go into labour with a non-head first presentation, and the diagnosis is made at some point during the labour, and those women will end up with often emergency cesarean section or taking the risks of an unplanned breech, which then can sometimes lead to death of the baby. So since we published our research, we were contacted by mothers who had had undiagnosed breaches, complications during labour with bad outcomes, and uniformly they were positive about the idea of doing a presentation scan, because it seems almost self-evident that it would be beneficial. The thing that we would caution is that there are lots of other things you can do when you do a scan. You can assess the size of the baby. Is it small? Is it large? You can look at the blood flow. And the clinical usefulness of these is a little bit less certain. because there's the potential for false positive results. We think the baby is small, we think the baby is large, and it leads to intervention which turns out to be unnecessary because the scan was a false positive. But in the case of presentation, it's a binary thing. Midwives currently try to palpate, the scan tells us for sure.
Yes, thank you very much. So you would say that in terms of breech presentation alone, that there is sufficient evidence to warrant that third scan at 36 weeks or so?
Yeah, so my assessment would be that there isn't a research question left other than what's the best way to implement this. I mean, would you have midwives, say, with handheld scanners? Would you have women attending hospital to be seen by a trained sonographer? To me, the outstanding research question is principally around how do you implement this.
Yes, and do you think it's practical in terms of the investment of manpower, essentially, the number of ultrasonographers that would be required, bearing in mind that there's been difficulty recruiting simply for what the current provision requires?
So when you're teaching junior doctors, any junior doctor in delivery unit would learn the basic skills to assess presentation out of hours as an emergency. And ultrasound assessment of presentation falls into that category of see one, do one, teach one. I mean, this does not require advanced levels of ultrasound skills, and it seems to me to be feasible. There are now point-of-care ultrasound devices, and staff could be trained to do this fairly simply. And the other thing you have to set against those costs of time in making the diagnosis versus the costs of time in failing to make the diagnosis. Making a diagnosis in labour in the middle of the night, staff being devoted to doing the caesarean section, resuscitating the baby, the whole delivery unit's emergency theatre being occupied for something that was potentially avoidable. All out of hours work creates risk. And so that investment of time to make the diagnosis antenatally seems to me to be potentially very worthwhile.
So in other words, what you're suggesting is a basic ultrasound scan to look at the presentation of the baby, as opposed to one that's perhaps looking at fetal abnormalities as well.
Yeah, so, or particularly growth abnormalities at that stage in pregnancy. Now, I do think there's scope for a late pregnancy assessment of well-being to try and pick up risk factors for stillbirth. And so that's a major focus of our research, is what can we do at that point just prior to term to have better risk stratification. So I liaise very closely with SANS, the Stillbirth and Neonatal Death Charity. They had a survey of their bereaved patients, and 60% of their survey respondents have been told they were low risk, and they went on to have a stillborn baby. And that's a manifestation of the fact that we're not that good with our existing tools at identifying risk factors for things like stillbirth. But the danger is, in our attempt to try and do something about stillbirth, we create lots of unnecessary intervention without actually preventing stillbirth. So for me, the stillbirth prevention side of it is still very much in the developing new knowledge. The breech presentation, to me, it's a question of how do you implement it.
Okay, thank you. I wonder whether our representatives from the Royal Colleges have any views on the deliverability of what's been suggested.
I'm happy to come in here. Thank you. I think Gordon's suggestions are extremely good, and the point of care testing, scanning for presentation is certainly in play in several units around the country, and indeed very successfully. It's in play, in fact, in my own unit here in Norwich. And so that certainly has efficiencies. The assessment of the small or the extra large baby or potential risk factors for stillbirth, I think that does open up quite a hornet's nest trying to work out whether it is appropriate. And as Gordon says, I think a lot of effort needs to go into researching this area so that we can get the right answers to whether we can do it, because fundamentally that will need quite a significant investment in sonographer time. Now, the sonography is a specialist area of sonography for maternity and pregnancy, and so we feel that if we were to add in another scan, then that would put significant pressure on the system that we have now to look at the details that scan would need to look at the risk for stillbirth, and also whether they're large or small babies. So overall, at the moment, I'm not sure the system could cope with that in terms of staff numbers. So it would need to be thought out very carefully. And therefore, I think probably research into it to get the most efficient way of learning from these scans would be the way to go, in my view.
Thank you very much. Jill, do you have anything to add?
Yes, I mean, I just build on what Eddie's just said. I mean, sonographers are a part of the workforce where there are huge shortages. I think it goes back to the women, women's choice as well, that if there is evidence that having a third scan is going to give them a better outcome if they have a breech birth, then actually the women should be part of the decision about whether to have that third scan or not. Women do have very clear views of whether they like scanning or they don't. So it will be, at the end of the day, all of these things plus the women's views, which is the bit we haven't mentioned. I mean, in terms of preventing stillbirths, I think we have opportunity to do that other than scanning. So Eddie, I'm surprised Eddie didn't talk about Tommy's funded programme between the RCM and the RCOG, the Maternity Improvement Centre, who at the moment are doing a huge piece of work on placental function with an app. So I'll let, hopefully there'll be an opportunity to talk about that. But I think all of these things link together to help all of us work with women to risk assess or to look at their risk of poorer outcomes, and that we all need to work together in trying to do that well.
Thank you.
Professor Smith, would you feedback in response to that finally?
Yeah, so when we did our research study, we actually went back to talk to the women who, years after the birth, you're imagining they might sort of say to us, what study are you talking about? And we interviewed 20 women who had a breach identified by the research scan and then subsequently intervention. And what we had fed back from, so midwife went to the houses and interviewed them, was universally positive. And you're really quite moving in a way. Women saying, I sometimes wonder what would have happened if I hadn't recruited to your research study, because nobody told me my baby was breached until I turned up for that scan. So I absolutely 100% agree. Everything we do in maternity is driven by the women who are coming to us and looking for care. And our experience of the women that we diagnosed with breech presentation was uniformly positive.
Thank you.
Thank you very much. Dr. Luke Evans.
Thank you, Chair. My first question is to Jill Walton, to pick up the idea about the stress that the staff are under. One of the concerns of clinicians often work under is the idea of defensive medicine, doing things to make sure that you don't get sued. I wonder how that fits in terms of being a midwife. Do you think, given the concerns and pressure that you've mentioned, is there a delineation between, added pressure by trying to make sure that you're not going to come a cropper?
Yes, I mean, I'm not sure that midwives go to work in the morning practicing so they're not sued. They go to work in the morning to make sure that they provide the best care they can to women. I think it's much more about midwifery leaders trying to manage the complexities of a service that is never the same day to day. Women don't go into labour at guaranteed times. That, some days you're extremely busy and other times you're really not. And I think it's about maternity services and maternity leaders looking at the whole and worrying about not having enough staff at a period of time that eventually leads to a poor outcome. And then it goes into that whole process of, has somebody been at fault? Has the system been at fault? If I raise the issues with my maternity staffing often enough, have people listened to me? So I think it's a collective issue rather than an individual issue. I think every maternity leader thinks all the time about, are we doing the right things to make sure that the best outcomes will happen? And I think really as an individual, being sued is probably the furthest from their mind.
Sure, that's really helpful, because some of the happiest and scariest times that I had in my training were on the labour suite and in the neonatal part. And that being said, do you think there's more that can be done to really prepare for those emergency moments? As we heard from Dr. Morris, particularly the team building side, do you think there's more that can be done to link the doctors and the midwives together so that they are prepared and fully drilled for it? If you take the comparison to A&E, do you think, dealing with a resus, do you think there's a parity between there? Is there any research around joining those two sort of thoughts up?
Yes. Multidisciplinary training, there's lots of research and there's lots of good programmes around that do that, and most services have to do it. The issue is that have they got time to do it consistently? Is it funded appropriately? Is the workforce, as I've said before, is the workforce funded appropriately to release staff to have the time to do that training and do it often enough so they absolutely have got it? The most important thing about multi-professional training is that it's multi-professional. Everybody does it. And I think that one of the things that we're picking up through all of today and various things is this issue of culture, that midwives, obstetricians and the wider team must work together, respect each other, understand what they all do, because they're all different. They're all doing slightly different things, so that women are really carefully in the centre of care. Now, training together and that multidisciplinary training, not just on the skills stuff, not just on the emergencies, but all of the things around, you know, the softer side of behaviour, how to talk to each other, how to, you know, all of the things that make a difference to the culture, that has to be funded appropriately so that every maternity service in the country is doing it. It's really...
Dr. Morris, you mentioned the workforce and trying to encourage people to join the workforce and that being an issue. What steps are you taking then to encourage F1 and F2s to choose obs and gynae? As you rightly pointed out, there's holes in every post, particularly in obs and gynae. What steps do you think you could take, and what steps could the government take to encourage people to choose your profession?
That's a really good question, and something that we often have to address in careers fairs regularly in regions, as I'm sure you're aware. It's really making the specialty as attractive as it can be, and it is the most amazing specialty. When you look at it, we're part of this incredible team that we've heard about this morning that bring new life into the world, but we also look after women throughout the whole of their life, so a full life course approach. And there's no other specialty that really offers those opportunities. And I think that's what drives a lot of people into the specialty. So as a college, we have an excellent training program, and trainees are supported throughout the program. So it's all about making it accessible to the trainees. But if I may, I just wanted to come back a little about the last question that you asked, Jill, with regard to the stress in the workplace and the team working. There's a thing that happens in medicine, and you will know this, Dr. Evans, and that is the fact that when you come on to do a shift, it's very rarely the same team that you work with on every shift. So every day you're making a new team to work on that shift. And that depends on teams working together no matter what level they're at. And in our project, Each Baby Counts, we looked a lot at human factors and how those influence outcomes and the ability for teams to work together on a day-to-day basis. And as Jill said, if teams practice together and work together, then when they form a team each day, then that helps with the culture in the system and reduces the stress on the output of the teams.
So just to pick you up on that point, is that an argument to say that especially trainee registrars and SHOs should have longer positions in post rather than 4 months or 6 months, certainly at the SHO level and into the registrar? Is that an argument to say that they should spend more time in a particular venue?
Certainly when the training posts went down for those who are getting experience to become general practitioners, when they went down to 4 months, that does have pressures on the system. But year-long posts are usually enough to get experience in a particular unit, because every unit's different. So during the course of a trainee's career, they will often go to large teaching hospitals, but they will also go to more rural or district general hospitals to get a breadth of experience, so that they can really see in the future which would be the best career choices for them.
That's really helpful. And final question from me. On that basis then, are you aware of any evidence out there that points to a rota pattern that causes these kind of problems? Indeed, the length of time they're spending in a trainee spending in a particular hospital. Is there a link that's been explored then, the 4 months, 6 months, years, 2 years, that you're aware of that could be detrimental to care?
The short answer is I don't think that research actually has been done. It's a very interesting area, and we're doing a lot of work at the moment looking at the workforce. We have a Vice President for Workforce and Professionalism now who's digging in deep to try and understand the complexities of the obstetric side of the maternity workforce, but as Jill has said, that involves looking at how the teams work together. So I'm hopeful that we'll get more information. I mean, when you look at some of the things that we had to do during the pandemic, our teams were massively disrupted, not just by people who were unwell and off sick, but also by redeployment of junior doctors to other areas of the hospital where it was felt that they were needed. So that was doctors taken from a pressurized area of the hospital to work in another area for something that you can't stop. You can't stop pregnancy. Pregnant women will keep on coming and they will continue to need the right care at the right time. And we found that 53% of units in our survey actually reported redeployment away from maternity. And so that made us able to create a very strong recommendation that if there was to be a second wave, and heaven forfend a third wave, that there should be no redeployment of under pressure trainees or maternity staff away from the delivery unit.
Thank you. Barbara Keeley.
Thank you. Well, I want to return to the question about normal births, and we've heard the terms good births and safe births used today. But in an earlier session, we did hear from bereaved parent James Titcombe relating to the Morecambe Bay tragedies. He told the committee that we need to change the very term normal childbirth. So I heard in terms of when the chair touched on this earlier, Edward Morris said we should ensure the culture around normal births is wiped out. But is it possible to change that? Because it seems to have become, in various reports, shown as a deeply ingrained culture across your professions that you represent from the colleges, with the view that they know more than the woman giving birth how she should give birth, as indicated by the use of that term. Clearly, we don't want to ever end up again hearing from people like James Titcombe, but also the mother earlier, who felt that she had let the midwife down through having a C-section. So can you both answer that question about normal births and how we just end that culture?
Okay, Chair, would you like me to go first?
Yes, please. Yeah.
Okay. So I mean, I was really saddened when I heard the story of the mother saying she'd let her midwife down. Obviously I can't comment on that case, but I think there is something about the relationship that midwives and women have where they work together. Now, it might be that the mother had said to the midwife, at all costs, I want to have a vaginal birth at home in a pool, and I want you to help me do that to the best of your ability. And it is something about maybe them both feeling that right.
Could I stop you there, because I don't think that's what we were hearing. I don't know if you heard all the evidence earlier. What we were hearing was from a group of black mothers who were campaigning now because they weren't even they didn't even have the options explained to them. So it definitely wasn't the case. They didn't have the information, and the midwife is pushing for normal childbirth.
Okay, sorry, I misunderstood that part of the question. I think you're absolutely right. It's about making sure women have the right information. And I think that's what I was meaning in terms of good birth. The most important thing is that women are helped to understand the evidence behind all the choices that they have. And it is clearly and explained to them and documented, and check back that they understand. And I think the most important thing then is that when women are making choices, whatever those choices are, whether it's a choice for a home birth or a choice for a cesarean section, that they understand really clearly the risks and benefits of those choices, because there will be risks and benefits of all choices. And then when the women are making those choices and understand the risks and benefits, then the health professionals, midwives and obstetricians then respect that choice. If their risks change, and I think this is part of Donna's report as well, it is about checking all the time what is going on in a pregnancy or during a birth to make sure that if the risk changes, that is then picked up on and then another decision made about what is the next choice. And the most important thing is that women are the centre of that decision making, that they are listened to by everybody who's involved in their care, so that at the end of the whole experience, whatever has happened, that the woman can report, I was listened to, I was involved in decisions about my care, I understood, and I had a good birth. That's what we want, all of us.
Yeah, I understand that, but you're talking about a pretty much idealised situation when it's compared to what we've heard from bereaved parents and what we've heard from the campaigning Black Mothers group. They haven't had that experience. They were pushed around by an ideology across your profession and the obstetric profession that forced them into a situation where they felt they had to have what's called normal childbirth. So how on earth do we do, you know, what Edward Morris said earlier, and ensure that that culture is wiped out, because it seems very damaging?
So I think we're already on the track to change the culture. Some of that is about the professions working together. We have something in the Royal Colleges and not just the RCM and the RCOG. We work with other Royal Colleges and with women's groups to have something called One Voice. And One Voice is how we look at all of those issues to make sure that we're all saying and doing the same things and that we're on the same focused track to move away from what you've just described, because that is not helpful. And it keeps damaging not just women's thoughts and experiences of maternity services, but it's also damaging to the professions who are trying to come together to change the culture of childbirth in this country.
Well, in terms of maternal and baby deaths, of course, it's more than damaging. It's completely detrimental to the care. Do you want to add to that, Dr. Morris?
Thank you. Yes, well, Jill has said a lot of what I was going to say, and certainly I was going to bring up the One Voice where the professions work together to try and address these issues. But Jill was talking about the fact that the woman needs to be at the centre of this. So this is all about correct and proper personalisation of the care that woman and her family get, and indeed what they want and is their right. And we need to help women make choices based on the right information. And this comes to what Jill gave you a little leader for earlier, and that's we can do this with technology and with the right data. There is a lot of data collected in the maternity system during antenatal visits and also during a woman's labour. And that needs to be harnessed to help the woman make choices during her pregnancy. So if we look at one of the projects that's underway and funded by the charity Tommy's, we are producing an app that collects the data of the woman's pregnancy as she goes through to help her make decisions based on her risk as it changes during the pregnancy. It's in the evaluation phase at the moment. It certainly does not replace proper antenatal care with the risk assessment that Donna so carefully delineated earlier. However, so that's one area of using the technology, and I think that will be important. The holy grail for a lot of obstetricians and midwives is that a woman, when she comes to labour, is fully informed and the information is accessible. And you're quite right that one of the problems that we have in the system is that there are bits of information for pregnant women all over the place, and nothing is centralised and easy to access, whether you're in a disadvantaged group or whether you're in a different ethnic group. And we heard about the difficulties with that earlier on this morning. One other area that I wanted just to briefly cover was that of the intrapartum care. So what happens during labour? How is the woman put at the centre of her care so that she feels involved in the right decision about her mode of delivery? Now, those of you who will have seen previous evidence given by James about the sad loss of his child, we could see that the decision-making processes there were not right. And also highlighted in our project, Each Baby Counts, is that during labour, the monitoring of the fetus has been a particular problem. Now, I've long argued that it's not just the way that we look at fetal monitoring that is the issue. It's looking at the whole woman during labour and regularly. And one big project with the RCOG and the Royal College of Midwives, and also with some leading academics and indeed families, we've been able to look at ways of improving the way that we assess a woman during labour regularly, every every hour so that we can understand what's happening to her as her pregnancy goes, so she feels fully informed and part of the process. This we hope we can roll out. We're waiting to hear whether this project has funding, but it definitely is going to be one of the ways of making sure that we stamp out this culture so that we can improve the way the woman feels involved in the decision making, and she can look back on her birth as being the best birth that she could have had in those circumstances.
And just as a final point, I mean, it's good the developments you're talking about, but where it has become ingrained, what chance, what possibility is there to stamp it out? Because it's a good thing to say we should ensure it's stamped out, but how plausible is it that that is going to happen, given that this ideology did seem to take hold and become ingrained in places like Morecambe Bay, and as we've heard via the Ockenden report?
I think you've heard today that Jill and I pretty much stand side by side on this issue. We're aware of cultural problems. We don't know where they are at the moment, and we know that there are units in trouble who may have those problems. And we think the system, so that is colleges working with government, working with NHS England and the devolved nations, we need to have a greater understanding of starting with the units that appear to be in trouble. The whole thing needs to be very much driven by the data that we get through the systems that we have at the moment. That data comes through very slowly indeed, and that needs to be sped up. And I'm meeting with the new officer for NHSX, who the head of NHSX for maternity, who hopefully will help us speed up the information. But fundamentally, we need to listen to women. We need to find reliable ways of capturing information from women, families where they're having problems, so that we can find these units, find where the culture is a problem, and assist the leaderships there to make the changes.
Thank you.
Can I just come in there, because I just wanted to add that how important it is that we all of us, so NHS England, the two colleges, work together on this maternity improvement with women at the centre of care. I think that going in with a supportive, with both ears, both eyes open, to really think about how we all work together to improve this culture. We can only do it together. I think it would be not the right thing for each college or just the NHS to go into services that they're worried about alone. I think we absolutely must do it together. And I think Eddie alluded to that. And so maternity improvement and at pace is all of our responsibility. And we are really signed up for that.
Okay. Thank you. Neil Hanvey. Do we have Neil? We don't have Neil, so we'll go on to Laura Trott. Oh, Neil, you're there. I can see you. Yes. Yeah. Fire away.
Yeah. I wanted to go back to some of the questions that I asked earlier of Ms. Ockenden, really around risk reporting and your view of how embedded that should be in clinical practice across all disciplines. And I guess without putting words in your mouth, going back to staffing issues and the chronic excessive workload that the King's Fund have spoken about, how much do you feel that chronic excessive workload influences clinicians to just put to one side, the importance of managing clinical risk in a positive way? Does that make sense? So you've got so much to deal with that having to fess up when things have gone perhaps not as they should have done. Can you give me a view of that? Just really about that whole.
Who do you want to ask that question to, Neil? Who do you want to direct that question to, Neil?
Oh, sorry, Jill, please.
Okay, so in terms of risk assessment, so there's the risk assessment for each individual woman, and I think you're absolutely right. When workload is high, sometimes the time and robustness by which that risk assessment needs to be done is lacking. So I think absolutely risk assessment, every point of antenatal care, labour care, postnatal care is really key, because things can change very quickly. So what could essentially be absolutely going fine, it's really important to be able to do risk assessment so that appropriate escalation to another appropriate professional is then made. I think there's also the risk assessment of the service itself. You know, it's not just the individual risk assessments, it's the risk assessment
that's
of
exactly what I was
service.
Yeah.
Of the service that I'm working in. And I think this leads, again, the leadership issue. Have we got the right numbers of midwifery and maternity service leaders, so that's obstetricians as well, understanding the complexities of the service that they work in? Because remember, a lot of the service is delivered outside of the hospital walls. It's out in the community setting. So do the people who are the leaders of the service understand the complexities and the risk of their service today? And do they have the right mechanisms to raise those issues at an appropriate level, whether that's a board, whether it's across the local maternity system, or even further? How are those mechanisms in place, and are they in the right level of the NHS in order to do that, so that they feel confident they've been trained and developed to work at that strategic level, to be able to raise those issues very clearly and quickly so that action is taken? I can talk from a midwifery perspective now. The RCM has been concerned for some time about the number of midwifery leaders that aren't in the right place in the NHS, that haven't had the training, the leadership development, or even at the level in the NHS Trust to be able to speak to the right people who can help them and unblock the way for to create a safer service when they believe there is a risk. But it also means that obstetricians and midwives need to do that together. And I think there's another issue about the leadership development of obstetricians in those leadership roles. Because of the current system, quite often a clinical director will come into post maybe just for a couple or 3 years and then disappear again. So that's going back to training together, even at a leadership level, in order to manage risk and constantly risk assess your service. Those teams need to be trained together, and they need to be at the right place in NHS systems so that their voices are heard. And that's what we want to see.
Okay. Can I just pick up on one point that you made earlier, Ms. Walton, which was around the constant pressure of savings and the, having to find money where there is none, and the temptation to cut staffing budgets, which could drive all of the things that you've been speaking about. In terms of that pressure, do you think that that's one of the reasons why perhaps boards have such a churn, because they're not able to really get on top of what needs to be done to improve when they have a pressure of being driven to cut services?
Yes, I think one size fits all sometimes under the pressure of cost improvement. I've worked in the NHS for a long time, and I found myself on many occasions have to justify the difference that maternity services, the different approach that maternity services should have in terms of funding and certainly cost improvement. I absolutely know there are still services today that have maybe midwifery vacancies, where those midwifery vacancies have been difficult to be filled, and so those posts have disappeared. So we absolutely know that we have to look at maternity services as unique, because it is unique, it's complex. We absolutely know that trust boards are managing complex hospital services, but actually the complexity of maternity services sometimes is hidden within all of that work. So a voice at the board is part of that solution, which is why we are really pushing for that. Thank you.
Neil, any more?
No, just if there's any other comments from the panel, they'd be welcome, but that's kind of what I expected to hear, but it's very helpful to have had that information.
Thank you very much. And finally, Laura Trott.
Thank you, Chair. We've had a series of maternity scandals in this country, culminating most recently in the devastating report, the Ockenden report, about the Shrewsbury and Telford NHS Trust. In many of these cases, we've seen that there's been data which has come up beforehand, which could have prompted early intervention, which just didn't happen. And too often it was parents that were pushing for scandals to be uncovered and for interventions to be made. What more can we do to act on early data on things like perinatal mortality, which we know, for example, at the Shrewsbury and Telford NHS Trust was 10% above the national average? What more can we do that we're acting on this data early to prevent such tragedies happening? And I'll probably go to Dr. Morris first, because you touched on earlier in one of your earlier answers about availability of data.
Thank you very much indeed. Yes, I think that this is perhaps the key thing. It's having an early warning system, for want of a better phrase, to really understand where units could be in trouble, and more importantly, where we need to focus and redouble our efforts. And I think whatever happens, the aim of this is to bring together the right people to go and help those units. And I think very strongly that this should be data-driven. The two colleges have worked together on several projects over the years, so Each Baby Counts, the National Maternity and Perinatal Audit, and we also helped shape the perinatal mortality review tool that Professor Karinchuk talked about earlier today. And so, as you heard from her, that is starting to give data, but it still doesn't quite bring together enough information quick enough to look at a unit that's failing. So what are the next levels that you could look at? So you could look at HSIB, but I don't believe, and I don't feel that is necessarily responsive enough. CQC are perhaps more real time. I understand from Professor Baker's submission to the committee that there's evidence given there that supports the fact that CQC are trying to look at perhaps a more frequent, a lighter touch look at systems within hospitals that could be failing. So there's stuff going on, but it just doesn't feel that well joined up. And both colleges and certainly our partners that we work with feel that something needs to be done to join this all up together. Whether we need a commission to look at the design of maternity services in the UK, or we need a centre that monitors the data, collects it, and comes up with an early warning system, we do need something like that. Certainly, as I said earlier, the speed with which the data comes through at the moment is still not particularly quick. It can take at least 9 months to get data, and so that is very hard to base some pretty important decisions on. So what we would like to see is a centralized data hub that is influenced by the professions and also by the women and the families that are supposed to be being looked after by the system. We don't feel necessarily that if it's got an entirely government running structure, that it would necessarily be clinically applicable and as reactive as we think it should need.
So just so I understand that, what's the structure that you're proposing? One whereby you have the Royal Colleges and NHS leaders and government? What will be the makeup of that you would suggest?
So the makeup of that is still very much in our thoughts at the moment, but we need to, so the data comes from maternity systems, but increasingly, as I said, with the Tommy's app, comes from actually a woman's pregnancy journey. Every time she engages with the maternity system, that will generate a data point, be it a blood pressure or be it a scan results, and that will feed into her own risk profile. And so that data needs to be looked at, and it needs to be analysed. And I think it could easily be an early warning system, a bit like a dashboard that not only takes the woman's individual data, but it takes the unit data. So very simple measures such as their caesarean section rate or their vaginal birth rate, but also merges with data from inspections such as CQC. And those things together then may be followed by a local visit to try and understand whether there are cultural problems in the unit, could then help us to really try to get to the bottom of units that are having problems.
Thank you. Ms. Walton, do you have any views on this?
Yes, I think at the moment, if you are working in a maternity service, it's a very complicated system out there. Data comes from all over the place. As Eddie said, CQC, HSIB, NHSR, the NHS itself, all the inquiries and the reports. And somehow we need to think of ways of simply pulling that together to make sense of it for the people that have to be trusted to make the difference, and they're the people who are providing clinical care and services. So I think what we're thinking about is how we build on the work we've already done. How do we have a wider and bigger collaborative centre that helps bring in the data, looks at joint programmes, looks at the research, and then goes with the health professionals working in services and support them to start making a difference. The key still has to be that it's about putting women at the centre. And some of the work we've already done, we've absolutely made sure that women are centre to the work. So Tommy's, for example, we absolutely are working with women on that programme. So I do think that if you were a practitioner working in a midwife in a maternity service today, it's complicated. Everybody is trying to find solutions and make a difference, but somehow that complication is halting the speed of that improvement. So the suggestion is to try and bring it all together. Both of our colleges represent most of the midwives and all of the obstetricians that work in the services. So we were in a good place to do that. And it's more bottom up then rather than top down. And we think that that could work.
Thank you. Then a slightly different question and a final question. We've talked a lot today at this session from various witnesses about the dangers of using the terminology normal birth and the implications that that can have for women's safety. Will both of you commit that your colleges will advise against using this terminology from now on?
Shall I say that first? Because I think I said it earlier on. I think normal birth as an outcome, I personally haven't used that for some time. I think it's through the lens of women's experience. It's a good birth for them where they have been very carefully involved in the decisions about their care. That is an approach that as a college we have been talking about for some time, and we need to keep talking about it. But we need to talk about it together, because I think there is, both of us, both colleges and both professions need to talk about that. But I also think there's a policy lead as well. There for some time, services were performance managed on things like their caesarean section rates and their forceps and ventouse rates, and were penalised when they went up. So I think we would like to see the right targets for maternity services and be promoting a woman-centred approach which is around good birth.
Thank you.
Could I just come in? Sorry, Laura, to interrupt, but I just want to go a little bit further, if I could, Jill. You obviously have a huge amount of influence on midwives up and down the country because you're chief executive of the Royal College. So just saying you're not going to use the term normal birth is not the same as saying you will ask your members not to use it in order to avoid some of the problems we're talking about. So I think that was really what Laura was asking, whether you'd be willing to commit to.
I think it's about how we have those conversations and the education and training of our profession. I think we can do that because we have all sorts of...
You can commit to not using the phrase normal birth.
There's a difference between normal birth as an ideology, which we do not support, and normal physiology, which I think we have to understand. So I think there is a difference. So I think that is the bit that's most important, isn't it? Understanding normal physiology and supporting women to have the choices that are right for them.
I think everyone agrees that we want to support women to make the choices that are right for them. But I'm sorry not to let you get away with this, but it is very important. Many people who don't understand, particularly for their first baby, will naturally gravitate to something that is called, inverted commas, normal. That's perfect, that's human nature. And so I think the question we're really asking is whether you're willing to encourage your members not to use the phrase normal birth as the professional involved, because that could exert a kind of hidden pressure on a woman to go for a certain type of birth when what matters is a safe birth.
You're right, and a safe birth is what is important, and I think we can support that concept of not pushing for normal birth. That's right. We shouldn't be doing that. Normal birth ideology, it has shown in the wrong hands to be unsafe, and we absolutely support the good birth concept, which is the right outcome for women.
Thank you.
I guess the point is, Ms. Walton, is that when you use the phrase normal birth, then people will think that that's what should happen. And it's not just about the ideology, it's also about that specific phrase, which can be so damaging and potentially dangerous for women. And I think what we're just trying to get out of you today is a kind of commitment that as a college, that phrase will not be used and will not be promoted. It's just really, really important because it does have a real impact on women.
I absolutely agree, and we haven't promoted that phrase, normal birth, for 3 years. So I think that you have, that is absolutely true. Now, what I can't control is every single midwife in the whole of the UK, but that is absolutely what centrally the college has been doing.
Thank you. And Dr. Morris?
Very similar to Jill's answer. As a college, we're not pushing for a normal birth. We don't support the ideologies that we've talked about at length this morning. What we support is the right birth for a fully informed woman and the safe birth.
So you'll commit that your college will not use terminology such as normal birth in the future?
Like Jill said, we will encourage people to use the correct language and not push for a normal birth. Therefore, I'm sure we'll avoid using that phrase "normal birth." It's unavoidable sometimes that it comes up in conversation, but it shouldn't be something that is used to put pressure on women to go for a delivery that they either feel isn't appropriate for them or is not perceived as the safe option. She needs to be fully informed as to the right way to have her baby for both her and for the carers giving her care at that time. So it's all about giving them the right advice.
And just a very quick final point. Jill mentioned the fact that maternity units are often monitored on the wrong things. So, for example, caesarean section rates, which actually might be driving the wrong types of behaviour. Is that a view that you share?
Monitoring units is a complex thing, and you can't look at a unit's performance through one lens like caesarean sections. At the college, we've been performing an audit that's been commissioned by the government indirectly called the National Maternity and Perinatal Audit, and that actually looks at these figures of performance in units such as pelvic floor damage rates or caesarean section rates or instrumental delivery and outcomes of the babies. And it is a very complex picture, and this is one of the reasons why we're pushing for a way to join together all these data points that come out of units, both before, during and after pregnancy, to make sense of how units are working. So you can't look at these units through a single lens.
Thank you.
Thank you very much. Finally, a quick question from Rosie Cooper.
Thank you. If I could direct this to Dr. Morris. There are those who believe we don't have a proper complaint system, a real complaint system in the NHS anymore, which leads to trust not learning. To deal with the problems that we've talked about right through today's hearing, you indicated you'd like a central data hub as it doesn't feel joined up. But regulators, and I'm talking CCG, NHSEI, Department of Health, you've got the Royal Colleges of Nurses, Midwives, the Medical Royal Colleges, you've got trust boards, medical staff committees, you've got local medical committees, you've got staff and patient surveys. This costs the taxpayer billions and billions and yet fails miserably. So should we be adding yet another layer or making accountable people accountable? Are you suggesting that we should just add another layer or reorganise the system as a whole? Because it's certainly not working and it can't go on failing and costing the taxpayer more and patients possibly their lives.
I understand your question. I don't think it is about adding another layer. In fact, I'm certain it's not about adding another layer. It is about using what we collect already, but using it better and using it in a timely fashion that fits the need. We've all talked about the fact that things need to change at pace. And I don't believe, as I see from inferring in your question, and I don't believe that at the moment it's moving quick enough. And that is because I think the system at the moment is under-resourced. I think the system does not move quickly. And I think whilst complaints are part of the metric that's collected, I would rather hear more from women about elements of their care in labour that we can improve, not just from the awful disasters that we've heard about today and in previous evidence sessions, but in the near misses, there's so much to learn from those near misses, and they may well be the subject of a complaint. And a team that works well analyses those near misses and feeds them into their governance sessions so they can learn from that. System-wide, if there's a way of collecting that along with what friends and family data is, then I think we can get even richer information as to how units perform.
Absolutely, but I suppose the point I was trying to make is that all this is there, so never mind doing it quickly or at pace or any of the other bits of modern parlance. These issues are around and been around on the table for a long time, and yet none of those organisations, from the Trust right through to the Department of Health eventually, but it could be years this is going on. So never mind doing stuff at pace and learning quickly, you're not even learning slowly.
I think for local units, part of their governance meetings in a department, such as the maternity department, will always include a review of the complaints that have come through. And certainly in my unit, which I hope most would see as a good unit, that's what happens. We sit down and we go through the complaints and we change the things that can be changed that are relevant to those complaints. System-wide, I agree with you, it's not moving quick enough, and we need to use taxpayers' money more effectively in that area.
Absolutely, thank you.
Thank you very much indeed. Well, that concludes this morning's session. I want to say a very big thank you to all our witnesses, to Dr. Morris, Jill Walton, Professor Gordon Smith, and earlier to Donna Ockenden and our two witnesses from the 5 Times campaign. It's been a very, very important session. Thank you all very much for your time. The session is now concluded. Order, order.